Hello, this is Dr. Laura Tigler. Welcome to my channel. This channel is meant to provide general medical information. It's not meant to provide specific medical advice. Please do see your primary care provider or your doctor to obtain medical advice that's tailored specifically for your needs. At the end of the video or the medical information, I will show you some spiritual information. If you do not want to stay for that portion of the video, I will let you know once the medical information portion is finished, and at that point you can simply click away. But first, please do like and subscribe. So today's topic is asthma, and I'm just going to test the screen to try the side-by-side method today. Let's see, I have to press it pretty good. Okay, so you should be able to see me and the slides. So I'm going to have to shift my head a little bit. Okay, so today's topic is asthma. I'm going to focus on some guidelines and specifically the updated guidelines in the year 2020/2021. I only say 2020 because the updated guidelines came out in December 2020 and then they were finalized in 2021. So if you speak about this, you would say 2020/2021. And my name is Laura Tigler. I am a senior specialist for the past several years, but I have been a primary care physician for all ages for 21 years in the past. Okay, so today's agenda, welcome to my channel once again. And I'm going to introduce to you some national programs, a global agency that help provide guidance on how we should manage asthma. And I already told you about 2020 and 2021. That was a big year or season. And I don't mean COVID. I mean about updating asthma guidelines. We're going to talk a lot about some inhalers, not all of the inhalers by any means. I would love to do another video on that. And then we're going to talk about things that have changed. So sorry about that blue dot right there, but NAEPP, that stands for National Asthma Education and Prevention Program. And so that's the main agency that updated the asthma guidelines in 2020/2021. And this program is underneath a larger agency, which is the National Heart, Lung, and Blood Institute of the United States of America. And then, of course, there is a global institution, Global Initiative for Asthma, or you can abbreviate that GINA. All right, so in the United States, these guidelines were last updated in 2020/2021, like I said. These guidelines are meant to support informed, shared decision-making among doctors and patients. And I want to emphasize the phrase shared decision-making. You'll see that more and more as we're getting smarter and smarter about all of the various guidelines we have about all of the various medical conditions, that there are times when we realize that, yes, we are smart, we have good algorithms, but it comes down to the doctor-patient relationship and deciding what the best course of action is. It might even include information that's not medical. The patient is of a certain socioeconomic status and cannot afford medications that have just come out and are very, very expensive. These medications might be on the guidelines. Like, for example, the SGLTs have surpassed metformin as the first-line treatment for diabetes mellitus type 2, but yet they're still very, very new and very, very expensive. So shared decision-making is very important. So these guidelines are taking that into account, and that way we can be informed. The Global Initiative for Asthma, these guidelines, they are updated annually. Please feel free to search your favorite search engine or AI and learn about the Global Initiative for Asthma as well. And these guidelines do tend to align with the United States NAEPP guidelines. I would say if you or a loved one is using a medicated inhaler, a prescription inhaler, make sure to check out these guidelines. Do some research. As I've said in other videos, I encourage you to read, 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 question, question, question. Write things down, talk it out, ask questions in a conversation. So there are 6 key areas where the 2020-2021 guidelines gave some updated information. And if you're older like I am, some of this is going to be very surprising. Sometimes when physicians and scientists get smarter and we change the guidelines, we almost turn 180 degrees on something. It takes almost, dare I say it, a leap of faith to really lean into the evidence and be scientific and be helpful. You know, we want to be helpful. We don't want to cause harm. So we really do have to go by evidence. We have to believe the data and make some changes, as hard as it might be to change. Okay, so the first key area is enhanced corticosteroid use, and I will talk about that in some detail. The next area is LAMAs. So we doctors abbreviate things. So I do feel that it's helpful for you to hear a video like this, even if it's somewhat over your head, or maybe the information doesn't pertain to you right now, but just to hear a doctor speak out loud, talk about a common chronic condition, it gives you an idea of the vocabulary. That might be helpful in a conversation. Sometimes the conversation with your doctor might be relatively short, and you want to be able to understand what she is saying. Okay, so LAMA, that's a phrase that will come off of our lips. And it stands for long-acting muscarinic antagonist. Immunotherapy, which we're not going to get into today, but I encourage you to read about it if you need to learn more information. Bronchial thermoplasty, we're not going to get into that today either, but please do read about it, or I can do a video if you put that in the comments. Indoor allergen mitigation, which we will talk about, and fractional exhaled nitric oxide. So I think that's kind of exciting to hear about the nitric oxide. So your brain might go to very different thoughts or areas of medicine when you think about that chemical. Okay, inhaled corticosteroids. So the abbreviation is SMART, S-M-A-R-T. The S stands for single, the M stands for maintenance, single maintenance, and reliever, R, reliever, therapy, T, SMART. I don't know how helpful that acronym is, but there you go. So in regards to inhaled corticosteroids, so cortico is just our way of describing the steroid more accurately. If you want to shorten it to steroid, you certainly can. It's just that there are other steroids in the body, for example, testosterone or other chemicals or compounds in the body that are steroids. So when we say corticosteroid, we are referring to the steroids that are specific for the respiratory tract. Okay, so one of the things that the new guidelines mentioned is that the use of an inhaled corticosteroid inhaler can be used for both daily maintenance, which is what we previously were doing, and rescue. That's new. Like I said, being an older doctor, when I see the word and rescue, at first I cringe. Like, what? Can that be possibly correct? We never did that before. And we were so strict and careful, like I'm being with you now. So to have it change is a big deal. Okay, and then another abbreviation that we use is LABA, L-A-B-A, and that a good example of that is formoterol. And that might be combined with a corticosteroid, and good examples of that would be Symbicort and Dulera. Those are the brand names. And then an example of a corticosteroid inhaler that's by itself, it doesn't have another ingredient in it, could be fluticasone inhaler that's commonly used. Okay, so up here on the right, for example, For a patient age 4 years old and older who has moderate to severe asthma, and I'm not even going into how we differentiate mild, moderate, and severe in this video, but I can do that in other videos. It would be appropriate to use a combination inhaler. Think budesonide and formoterol. So the budesonide is the corticosteroid, and the formoterol is the uh, long-acting beta agonist. And so that's combined, and it might be a brand name like Symbicort. Okay. And so you can use that for maintenance every day. But then if you're having difficulty breathing, like let's say your trigger is low barometric pressure, like a rainy day is coming and you feel that you can't breathe very well and you need a rescue. So now you don't just have to use that plain rescue inhaler, a separate inhaler. You can use that same inhaler with the two ingredients in it and use an inhalation of that medicine to rescue you. Isn't that interesting? All right. And then the inhaled corticosteroid component helps lower inflammation. So basically, steroids help lower inflammation. So an acute exacerbation of asthma has two components to it. The bronchial tube itself might be constricting. So it's not very dilated, it's constricted, restricted, smaller. But in the lining of the tube, well, that's not very clear, is it? In the lining of the tube, it might have some inflammation and it's getting thicker. So, and that in effect is decreasing the diameter of the tube as well. So there's two ways that the person suffers and can't get the air in and especially out. So the inhaled corticosteroid lowers the inflammation, and the long-acting beta agonist, you might think formoterol, helps dilate the bronchial tubes, like I was showing. Okay, so the benefits of the enhanced inhaled corticosteroid use. There are multiple benefits. Number one, it lowers the risk of severe exacerbation, which is the end game. It is the goal. We want the patient to do well on maintenance and not have to have a severe exacerbation, especially not end up in the hospital or the emergency room, and especially not die from an acute asthma attack. The enhanced inhaled corticosteroid use also helps lower steroid exposure overall, which is fascinating. So we were using a medicine like that as a maintenance, and we weren't using that as a rescue. And then we were doing other means, like say a short-acting beta agonist, which you might think of as your regular rescue inhaler. And I did talk about albuterol in a prior video, and I encourage you to go listen to that one again. That's an example of a short-acting beta agonist. And I did a whole video on that. And I didn't even cover everything I would love to cover. So this can get very deep. So you're having the inhaled corticosteroid, and you can use it as a rescue. It works well enough that you don't end up going into more severe exacerbation, and that overall lowers your steroid exposure. Steroids, these steroids that we're talking about today in this video are essentially topical. They're going to be landing in the surface area of your bronchial tube. But there might be some absorption, and if you're using it on a regular basis, your systemic absorption of it might not be negligible. So it does matter. And also sometimes when someone has an asthma exacerbation, we actually give them systemic steroids, either by mouth or by a shot or some other means. Okay, if the patient is not compliant with the twice daily maintenance, say of a Symbicort-like medication, which has the budesonide and the formoterol, then they will get a dose of the inhaled corticosteroid when they use that inhaler for a rescue. That itself, having that extra steroid, and it's really not extra in a patient that's non-compliant, is it? It's really kind of taking the place of, but that steroid will help keep the inflammation down. Use of an inhaled corticosteroid whenever a short-acting beta agonist is used. That's new. Okay, so if you do have an albuterol short-acting beta agonist, and you can't breathe very well, now you can add on the use of your inhaled corticosteroid. Ask your doctor or provider if it's just a plain old inhaled corticosteroid or if it's a combination, if you can do that. Because if you get double beta agonist medication, that might have some consequences. But this is in the new guidelines. Okay, and then a short course of high dose inhaled corticosteroid for early symptoms. And that just means you could actually take a higher dose of your inhaled corticosteroid, let's say the fluticasone alone inhaler that I was speaking about earlier, and it's topical. It's not going to be taken orally or injected in the muscle or injected intravenously. So that's more advantageous that you're not getting the steroids systemically. It's going right to where it needs to go, focused or topical. And so the guidelines do account for that. Okay, so for example, a patient with moderate asthma may take 1 to 2 puffs of a budesonide formoterol, Symbicort, combination inhaler twice daily for maintenance. So that's what they were supposed to do, twice a day, moving right along. And now they may use that same inhaler for quick relief instead of a short-acting beta agonist. So this is a very important slide. If you have asthma or you've had it for years or you have a family member with asthma, you want to read. Don't just go by my YouTube video. You want to read, do the research first line yourself and go read the guidelines yourself. But like I said, it lowers enhanced use of the inhaled corticosteroid use, lowers the risk of exacerbation, which is obviously a great goal. It lowers total steroid exposure, whether it's topical or systemic. If the patient is not compliant, then it will help as a rescue and give a bit of a steroid dose. You could consider using an inhaled corticosteroid whenever a short-acting rescue inhaler is used, which had not been part of the guidelines before. And then, of course, also short course of high dose inhaled corticosteroid for early symptoms. Okay, childhood asthma. The 2020-2021 updated guidelines changed the stepwise approach for children ages 0 to 4 and children ages 5 to 11. I am currently a senior specialist, so I'm not going to go in deep with the childhood recommendations, but I do encourage you to ask your pediatrician or family practice physician about those new guidelines. And then the childhood asthma guidelines, they're favoring increased use of controller medications over only rescue medications like the short-acting beta agonist, which is similar to what we were talking about for adults. Okay, so this is a different class of medication. It's called LAMAs or long-acting antimuscarinic agents. You're used to the B, short-acting beta agonist, long-acting beta agonist. You really might not have much exposure to the LAMAs. So the LABA, the SABA, and now the LAMA. But I thought I'd throw this in because the updated guidelines do make some changes with these medications as well. I'm just going to give a couple of examples. But if you have asthma or COPD or chronic bronchitis or emphysema, then you really do want to do your own research and make sure you have a good conversation with your provider. Okay, so the LAMAs are good for add-on for uncontrolled asthma. And this might be in a patient who's already taking inhaled corticosteroid or long-acting beta agonist. And I'll even make it even more complicated. So you can do that. You can add it on and have all three of these ingredients in ICS, inhaled corticosteroid, LABA, LABA, and a LAMA, or you could change it out. So let's say the patient was taking the inhaled corticosteroid mixed with a long-acting beta agonist, and you might just say, okay, I'm just going to change it to inhaled corticosteroid and a long-acting muscarinic agent. So you will the provider or doctor like myself will have a conversation with you, hopefully share decision making, or at least tell you what's best and why. Um, and then llamas, sometimes they bind to M3 receptor, sometimes they bind to M1 to M5 receptor or another specific receptor, but they're all muscarinic. And the muscarinic receptors, when they're bound by the llamas, they do prevent airway constriction. So effectively, they relax the airway muscles. And that's what we want. We want the diameter of the bronchial tube to be larger so more air can flow. The llamas do reduce exacerbations. They improve lung function. So how much air I can breathe in at one time and what the efficiency is of my exhale, how much I can exhale. And we have the pulmonary function test. That's a diagnostic test for asthma that we measure those and many other parameters for your breathing. And then the long-acting anti-muscarinic agents, they are commonly used for COPD, which I do have a video on COPD. Okay, and I just want to give you a couple bits of information, miscellaneous information on tiotropium. You might think of that brand name Spiriva. It's for uncontrolled asthma, like I mentioned up here on the left, but it could be used for COPD. It's for ages 6 years old and older, and it relaxes the airway muscles. Another example is umeclidinium, and that's for chronic bronchitis and emphysema. So this talk is mostly on asthma, but like I say, we are touching on other respiratory illnesses. And this particular LAMA could be combined with the LABA, for example, in these cases. And then this also relaxes the airway muscles. Okay, so we're going to talk about another key area about the guidelines from 2020, 2021, and that's indoor allergen mitigation. So, as I've said, I am very knowledgeable about the prior guidelines, and we used to recommend the patient to do all of the mitigation that we could think of for that patient. And that could include, this is not an exhaustive list, but that could include pillow covers that you might have to buy. It might be a bit expensive. Wash the bed linens in hot water, and that's expensive because that means you have a higher gas bill. Change the mattress every 8 years. Obviously, that can get expensive. Wipe hair with a damp washcloth when coming in from outdoors. Take off jackets inside out so that you just don't release too much pollen in the house. Change clothes when you come home because pollen might have be stuck to your clothes. Wash those clothes. Close the windows, shutters, not curtains, hard flooring, not carpet. And this can lower the risk of an overgrowth of dust mites, etc. But now here on the right, we want to target aggravating factors. So let's say pollen is really the biggest problem, then that patient's going to have to focus on maybe just wiping their hair when they get in the house and closing the windows. So you want to tailor the interventions for specific high yield improvements in symptoms and improving the chronic condition of asthma. Okay, and this is another key area. I just thought it was fun to add this in. Fractional exhaled nitric oxide. So when we exhale, a lot comes out in our breath. You might remember the biology from school that we breathe in oxygen and it's going to the little alveolar sac and it's diffusing, and then the capillary membrane is right there. The oxygen goes into the little capillary. It piggybacks onto the hemoglobin molecule, which is on the red blood cell, and it carries the oxygen throughout your entire body. And in the same way, the carbon dioxide diffuses through that very thin membrane and is in the alveolar sac, and then I breathe that out. So that's the essential respiration, but we can also breathe out, let's say if we have an infection in our stomach by a bacteria called H. pylori, we can actually breathe that out, and we can detect that with a certain breath test. You're all familiar with the breathalyzer. We can exhale alcohol. You can smell alcohol in someone's breath. And this is just another example. Nitric oxide is present in a greater quantity, a greater number in a bronchial airway that's inflamed. So when I'm exhaling, we have found a way to measure how much nitric oxide we're exhaling. So this particular breath test is very simple, usually would be done in a pulmonary specialist office. It can provide guidance to treatment, but it's not going to be used as the only thing that's going to guide treatment. And it's not intended to make a diagnosis. As I said, the pulmonary function test is really the diagnostic test along with the chest x-ray and of course the history that you give the doctor and the physical exam that the doctor does. But it can be used to monitor treatment. So it is a helpful test. So thank you so much for staying with me for the asthma portion of this video. We are going to have a few more minutes of spiritual information. I am going to give you a couple bonus slides to look at reviewing the information that we just discussed. But if you don't want to stay for the spiritual information, now is the time to go ahead and click away. But first, please do like and subscribe. So I wanted to remind my viewers that I do have an author website. It's right here, lauratigler.com. And if you could please consider buying my books or sharing them or giving them as a gift. You're Saved is my nonfiction first book. It's theological in nature and it's primarily about salvation. And my second book is called An Impossible Situation. It's a work of fiction, and I do highly recommend it as an entertaining read, but for adults only. Okay, so now I'm going to go ahead and stop sharing momentarily. And then I'm going to go ahead and share again because I want to show you a fun picture. Okay, so you should be able to see this picture. Actually, I'm going to stop sharing and share again and just give you the content only. I'm getting fancy now. Watch out, guys. I'm learning. Okay. All right. So now you should be able to see, and actually, that's not what I want you guys to see. One second. There we go. Content only. Okay. So now you can see this here is the normal airway, and there is a bit of natural thickness here. And there is some nitric oxide, but this is the normal levels of nitric oxide. These are bronchial tubes, and they go deep in our lungs here. And on this right side here, there's higher levels of nitric oxide in and around the lining of the bronchial tube. And you can see that this person's bronchial tube is thickened, more inflamed, and obviously more constricted. So it's harder for air to go in and especially out. So I'll leave this here a moment in case you want to take a screenshot. Okay, so I'm going to stop sharing. Now I'm going to share one more time, just something academic. This one right here. Okay, so that's the content only. And so this is just an AI prompt that I made for muscarinic receptors. And I just wanted you to see how interesting and complicated it is all at the same time. So the muscarinic receptors are G protein coupled receptors activated by the neurotransmitter acetylcholine, primarily mediating functions of the parasympathetic nervous system. And you can look that up. What does the parasympathetic nervous system do? What's it in charge of? For example, the parasympathetic nervous system likes to help us slow our heartbeat, but it also constricts our bronchial tubes, constricting bronchi, which just is a way to say constricting the breathing tube. Not the trachea, but when the trachea branches off, the larger tubes that come off the trachea or the main airway is called bronchial, they're called bronchial tubes. So the muscarinic receptors are in those bronchial tubes, and they can get constricted if we have a stimulation of the parasympathetic nervous system. But the parasympathetic nervous system also likes to increase gland secretions, like the sweat glands. But here it's saying, but also controlling the sweat glands. And then it goes on to explain M1, 2, 3, M4, and M5, and what they relate to. So I thought you'd be interested in seeing that. Okay, so I'm going to stop sharing. Oh, and of course, you guys know I really enjoy chemistry, and it's always enlightening and enjoyable to actually look and see what the chemical structure is of our receptor in our body, but also of any treatment that we might be giving um, ourselves or others. Okay, so now we really are starting with the spiritual information. As many of you know, I am a devout Christian. I am not trying to proselytize, but I do have a firm belief that salvation is key, that we humans come to this world and that is very important that we gain salvation. And you'll find this concept in all of the major world religions. In fact, as I told you, my first book explains really how to be saved. It gives you somewhat of a pathway. And you can look this up on Amazon.com. And hopefully you enjoy reading this. I believe it's excellently written. And my second book, it is a work of fiction, but the hero in the book is a woman of faith. And it does combine Christianity and Hinduism in giving a coherent spiritual story in the context of a mystery thriller. But my spiritual lesson today is about energy. And that, especially as a Christian or anyone that has a more disciplined mind, say Buddhism is very good at disciplining their mind. I would venture to say almost any of the major religions, if practiced diligently, will guide you to a deeper discipline and more self-control, a deeper happiness and peace with practicing prayer and faith. Um, and I would venture to say that, as we say in our Christian walk, that what we say, our words, our thoughts, and our actions are all important. So it's not just our actions. If you're having negative thoughts and you're saying mean words to others, that's very harmful. And all of these things have a certain energy to them. So these things actually equal energy. And as you know from metaphysics, there are many different concepts and philosophies about matter being energy, but I would say that we are primarily spiritual beings. We're not primarily physical beings. And in the Christian faith, we say that we want to treat our body as a temple of God. So we are in and around our body. Um, but this body isn't who we are. It's made from God. But who we are is essentially a spiritual being made of energy. And so you want to be kind to others, not just because it's societally polite, but because you don't want to hurt them. So if you have mean words or bad thoughts, or especially even actions, let me give you an example, like you're gossiping or you're committing slander against someone, you're talking ill of someone, and it serves no good purpose. It's mean. It's bringing that person down. It's bringing you down. It's bringing the person you're talking about down. It's not helpful. Or you're writing and you're putting someone down. And that it might be unintentional, but you need to be careful. So all of these things carry an energy, and ultimately everything comes from God, but we have to believe that, or we should know that there are some negative energies or energies that are not so positive. And so you don't want those to affect you. So you want to protect yourself with love, and also just try to make a habit of being careful about your words, thoughts, and actions. They do carry energy. And so you want to exhibit self-control. Um, And I'm thinking of Corinthians 13, if you want to go look that up. Okay, so this is the end of today's video. Thank you so much for staying with me. I really appreciate it. Take care. See you next time.